All right. So we're going to start off here. This is the beginning lecture. There's two parts to today's talk. We're going to try to cover part one right now. This whole talk for today, the goal is to understand what kind of exposure levels, what kind of exposure to radiation our patients receive when we're doing exams on them, and how we can do things to minimize that exposure, or maybe just shield parts of their bodies from that exposure. That's our goal. So two parts to this lecture. This first part is just going to talk about what are the exposure levels that our patients receive during regular procedures. So really we're just covering exposure numbers right now. A couple notes. We're going to look at a table here, this table, in just a moment. You can feel free to have your books open to this table if you like, or your notes that I've sent you open to this table, but let me make a few notes on that. When we talk about the distributed skin exposure on in this next table, distributed skin exposure means the entire amount of exposure given for a whole X-ray procedure. So, certain X-ray procedures, most of them have more than one image, right? A chest X-ray has two images, a hand X-ray typically has three images, and so on, right? These body parts that we radiograph, we take several images of them. Each exposure, rather, each image we take gives the patient some exposure, right? If you add up the exposure for all of those images, that's the distributed skin exposure. So it's the exposure integrated across all of the images that we take. So it's not the exposure delivered to any particular section of tissue because it may be spread out over different projections to different portions of the skin, nor is it the scientifically ascertained dose to the patient, which would be measured in a different unit called rads. Distributed skin exposure, as I just said, is defined as the summed total of the entrance exposures representative of the radiographic procedure. Entrance skin exposure is the amount of radiation that some body would receive before it's gotten into the body, right? So you can imagine like shining a flashlight at yourself, right? Or shining a flashlight at somebody. The amount of light that hits their skin would be like the entrance skin exposure for the X-ray beam, right? We make an X-ray beam, it shoots out of the machine, and the amount of X-rays that could absorb into their body that hits their skin, that's the entrance skin exposure. We know there's a relationship between exposure and how much absorbs into our patients, right? What's that relationship between exposure and absorbed dose? They're roughly equal, right? And they're only roughly equal for X-rays, right? So when we make an X-ray beam, right, we expose our patients to the X-ray beam. Almost all of what they're exposed to, they absorb, okay? Some of it has to be able to pass through the body, so we know that can't be exactly true, right? The X-ray beam has to be able to pass through a patient in order to get to an image receptor behind the patient to make an image, right? So it can't all absorb in the body, but more or less, the entire X-ray beam is absorbed by the patient. Okay, it's roughly 96% of what they're exposed to they actually absorb, but more or less we say there's a one-to-one relationship between exposure and amount that's absorbed. The exposures listed on the next table are going to assume the patient is of the patient is of average thickness, and therefore average radiographic technique is used. So let's make sure we break down. I put radiographic technique as a term on this key terms thing, but let's make sure we understand why patient thickness has any role to play. So what's the role of patient thickness with regard to exposure?
The 4 centimeter rule.
Sure.
The bigger the mass, the higher the kV. Let's raise
kV or mass. So let's talk about like the X-ray beam, right? We make an X-ray beam, and let's analogize to, we make an X-ray beam, okay? That X-ray beam has to get through the patient in order to hit an image receptor behind the patient in order to cast that shadow of the body, right? A thicker patient would absorb more of the X-ray beam, okay? Roughly speaking, every 4 centimeter increase in thickness absorbs half of the X-ray beam. Yeah, so if you had a 4 centimeter thick patient, you made an exposure, got your image, and then your next patient was 8 centimeters thick, and you didn't change anything, you didn't make a brighter X-ray beam, you didn't make more X-rays, That next image on the 8 centimeter thick patient would be a lot lighter because more of the beam would be absorbed by that thicker patient. Yeah. Patient thickness matters because the patient's body absorbs the X-ray beam and doesn't let it through. And thicker patients absorb more of the X-ray beam. For this exposure, we're thinking average thicknesses, okay? A large patient compared to, so you have like small, medium, and large, right? Medium sort of average. So a large patient would have a higher exposure per exam per image because you have to use more radiation for that larger patient, yeah? A smaller than average patient would have a lower exposure. What we're talking about on this upcoming slide is average thicknesses, average patients. And it should also be remembered that the listed exposures are partial body, not whole body exposures. You know, you can go out in the sun and keep yourself almost entirely covered and then just get like a sunburn on like the little exposed part of your hand, right? It's like a partial body exposure. Or you can go out in the sun with, you know, no hat, no sunscreen, no shirts, no towel, no umbrellas, no nothing, and then you get a whole body exposure and your whole body gets, you know, turns up lobster red, right? So that's sort of the difference between partial body and whole body. We're assuming partial body exposures. What's worse, partial body exposure or whole body exposure? What do you think? Whole body, right? We have a unit for absorbed radiation. We call it the gray, okay? 1 gray of radiation to the whole body is enough to cause death, okay? But 1 gray to your, you know, index finger and not the rest of your body is nowhere near enough to cause death. It won't even redden the skin on your finger, okay? So whole body exposures matter much more than partial body exposures. In the X-ray room, because we're sort of limited, our X-ray field doesn't get very big, right? Our light field can't get, you know, whole patient sizes, right? So we only make partial body exposures. That's important. Whole body exposures count for more. All right, let's take a look at this slide here. So again, if you have this, you can look on here and you can find one of the bullet points that has the unit called the gray. It's actually the third one down. So just a reminder, we have to measure radiation, amounts of radiation, like we would measure, I don't know, things like the brightness of a flashlight, right? You can measure those things, okay? Well, we can measure the amount of radiation someone is exposed to, okay? The unit that we use for that is called the gray, okay? And we don't worry about why it's called the gray, we just accept that that's the unit we use called the gray. 1 gray of radiation to the whole body is enough to cause death. So that's sort of, you can have a feel for, you know, when things become lethal. 1 gray. 1 gray is a lot of radiation in other words, okay? It's a radiation unit to measure exposure as well as absorbed dose. Common diagnostic procedures, the ones that we do in the X-ray rooms, give patient doses measured in microgray or milligray. A microgray, 1/1,000,000th of a gray. So at 1 microgray, 1/1,000,000th of a gray, so it's millionths. Milligray is thousandths, right? A milligray, 1/1000th of a gray. Okay, so now we have our unit, and we've got the fractions of that unit, milli and micro, to talk about. Let's take a look at some of the natural background. So this will be maybe news to the new students. You're exposed to harmful radiation all of the time, okay? Very small amounts of it, but you're exposed to it all the time. Just being on Earth, alive, having a body, exposes you to radiation. Your own body has radioactive chemicals in it, radioactive particles in it, okay? So we're exposed to radiation all the time. We call this natural radiation, we call this radiation that we're exposed to all the time our natural background, okay? Natural background accounts for about half of all the radiation that you'll receive in a year, okay? The other half comes from medical radiation. So of all the radiation someone receives in a year, half of it comes from medical radiation, about half of it comes from natural background. The annual natural background, you see it at the top there, 3 milligray. So 3/1000ths of 1 gray. Not a lot, right? 1 whole gray is enough to cause death. In 1 year, just being alive on Earth, you get about 3 milligray, okay? Most of you have heard of Chernobyl. A lot of you have heard of the atomic bombs used at the end of World War II, Hiroshima and Nagasaki bombs. The Hiroshima bomb administered about 2 gray to all of the people that were close enough to it that didn't get vaporized. Okay, so if you survived it, and you were there, but you survived it, you got about 2 gray worth of exposure, enough to kill you. Okay, some people did die, some people didn't die from the exposure, but it's a lot. The point is that gave people a lot of exposure. Even the Chernobyl disaster in the late 80s, with the nuclear power plant that exploded, that gave people 450 milligray, right? Way more than their lifetime's worth, right? So if you look, they take it and they turn this, you could turn this into equivalent risk, right? The annual natural background in equivalent risk is equivalent to driving 96 kilometers, right? In equivalent risk, the Chernobyl exposure is equivalent to driving 14,000 kilometers. Why driving? Why is driving a risky thing?
Risk of accident.
Risk of accidents, right? So they're taking basically the amount of radiation received, how harmful that is, how risky that is, and converting that into other types of risk, right? Driving a car, smoking a cigarette. This, I think, is pretty impactful. The Chernobyl survivors, just in that one incident, got 150 years worth of natural background radiation. So it's as if they were alive for 150 extra years just because they were exposed to that incident. Look at the Hiroshima people. 700 years worth of natural background they received. Okay, so this is your frame of reference. Okay, these natural background, these incidences are your frame of reference. Oh, by the way, transoceanic jet flights, 50 microgray, so a lot smaller than a milligray, right? But there's something there. Okay, some exposure from a transoceanic jet flight. It's equivalent to smoking half a cigarette. Okay, why do you think flying in a jet gives you increases in exposure above what we get here on the ground?
You're above some type of layer.
Yeah, right? What do we have above us that protects us? We breathe it, right? It's our atmosphere. Then there's different layers to our atmosphere, right? One of them is the ozone. But the point is that we have an atmosphere, right? That atmosphere stops some of the harmful particles coming from the sun and other stars from reaching us. Yeah? If they were able to reach us, they would cause lots of harm. Okay? When you're in a jet airliner, you're 35,000, 40,000 feet, right? You are not above the atmosphere, but you are way higher in the atmosphere than we are now, and it's much thinner up there, and there's much less in the way. There's much less blocking those cosmic rays, that radiation from reaching us, right? So you're exposed to more. The aluminum of the airplane does almost nothing to help you. Okay, it's very, very thin aluminum, right? And does nearly nothing to help you. So you're up there very high, and you're basically completely exposed to, at least as far as the radiation is concerned. Okay, so there's our frame of reference. 6 days of natural background equivalent for that transoceanic jet flight. So your flight attendants, your pilots, those people who do it all the time, they're getting an increase in radiation above what the average person gets, right? They're going back and forth all day long. Okay, so frame of reference. Now let's move down to our exposure, our exams that we should be getting familiar with. What's the most common X-ray procedure? Diagnostic X-ray procedure? Chest X-ray, right? And it usually involves 2 images, right? So a 2-view chest X-ray is by far the most common X-ray procedure that you will learn. It's the most common one that patients get. It's ordered all the time, okay?
What if you do 3?
What if you do 3? What would be your 3rd view?
You messed up.
A repeat? Yeah. So there is a 3-view chest X-ray series, and it includes an image called the AP lordotic. Has anyone done that view before? AP lordotic? You tilt the patient back. So normally, like a PA or an AP, they're standing chest against the board or back against the board, right?
Yeah.
The AP lordotic, they lean way back like this, and what it does is it effectively raises the ribs up out of the way, and you can see the apices, the tops of the lungs better. You guys know what diseases like to live in the top of the lungs? There's one very important one.
TB?
Yeah, TB, tuberculosis. Tuberculosis is, and I'm going off track here, but tuberculosis is an aerobic bacteria. It's a bacteria that likes oxygen, and oxygen is air, right? A gas, and gas likes to go up, Yeah, so in your lungs, your higher oxygen environments will be up high. Okay, so TB is found up high more readily than it's found down low. Anyways, that was a digression. That would be your third view, though, right? Okay, so a 2-view chest series, which is the second one down here, right? That gives 1 milligray. Okay, so it's the most common exam. Many people get a chest exam every year, but that 2-view chest exam, even at only 1 milligray, that's equivalent to 4 months of natural background. It's adding on 4 months of natural background to this patient's life, right? Again, and let's put that into other equivalent risks. It's equivalent to smoking 10 cigarettes, yeah? Or driving 32 kilometers. It's dangerous to drive, right? 32 kilometers is equivalent to 10 cigarettes worth of risk. That's a lot. But there you go. There's your most common exam, coming in at only 1 milligray, 1/1000th of a gray. So if I gave you 1,000 of these all at once and made the exposure to your whole body, then that's enough to cause death, right? So it's still very small. The point is I was trying to relate that it's very, very small still, right? Okay. Other exams. So let's move down. Another common exam is a back exam, okay? A lumbar spine, a 3-view lumbar spine, okay? 3 views is sort of the typical amount of views, the typical images that you take for lumbar spine. You do the front view, you do the side view, and you do something called a spot film, or L5S1, right? It's a third image, right? So 3 images of the lumbar spine. Down here is roughly the same thickness as up here, right? But different tissues completely, yeah? We have air-filled tissue up here. It's not very dense. Your chest is not very dense at all, right? Whereas your abdomen has all of these blood-filled organs in them, right? Your liver, your gallbladder, your spleen, your stomach's full of liquid, right? Your intestinal tract is full of liquid and fluid and food and all that stuff, right? Plus your spine. Your spine, your pelvis is all down here, right? So there's just a lot more going on down here. These tissues are a lot denser, okay? And denser body parts require more radiation so that the beam can get through the body, okay? So a chest x-ray will have less exposure than a lumbar spine x-ray. So let's look at the lumbar spine. Lumbar spine, 50 milligray. How's that compare? That's all 3 views, right? That's the distributed skin exposure for all 3 views. It's not just a single view. But a lumbar spine, a 3-view lumbar spine, is worth 50 chest x-rays, okay? That's a lot, right? Every 3-view lumbar spine you take is like you did 50 chest x-rays on that patient, okay? That's quite a lot. Let's compare this to other things. It's equivalent to smoking 400 cigarettes, driving 1,600 kilometers, or, this is kind of impactful, 17 years worth of natural background, okay? So physicians really have to consider, do you need this x-ray today, right? Is it that important that we take this x-ray, that we give you the risk of the radiation, right? That we just forego the risk of the radiation exposure for the information that we're gonna get from it, right? We hope we're gonna get good information. That information comes with a risk. If the reward is higher than the risk, let's do it, right? If the risk is so high and the reward is very low, then we probably don't do it, like if she's pregnant or something like that, right? The reward is very low compared to the risk. But yeah, it shows you quite a lot, right? Let's come down now to even higher level exposures that are less common. Well, that's the bottom, okay. That are less common. So now let's go to one of the highest level possible exposures. You've got angiography, okay? Angiography is done under fluoroscopy, which is video x-ray. So where we have like plain film x-rays, like, I won't turn it on, plain film x-rays like these guys, right? Single plain still images. Fluoroscopy allows us to do dynamic stuff. It allows us to move the body part, right? And see it moving on the screen, okay? Video x-ray. As you can imagine, right? What is a video, right? A video is just a bunch of still images played one after the other, yeah? So in x-ray, it's the same thing. We have a bunch of, for fluoroscopy, it's a bunch of still frame images played one after the other. Well, each one of those still frame images was a separate exposure. So we just make exposure after exposure after exposure after exposure, and we build up this series of still frame images, very much the same as video works. Okay, it's a bunch of still frame images. So lots of exposures during a fluoroscopy procedure. Angiography is blood vessel imaging. It requires that you use very close distances. Your x-ray machine has to be very close to the patient, and the technical properties of the machine make it higher level exposures than other types of equipment. Okay, so there's internal stuff about this machine that makes it a little different. But an angiography series with 5 minutes of fluoroscopy time, that's just 5 minutes of accumulated exposure, right? You know your exposures last milliseconds, right? Well, this is 5 minutes, okay? So quite a lot, okay? But we have to do it for certain reasons, right? So 5 minutes of fluoro and 16 overhead or spot films. This is basically 16 extra plain still images, okay? Chest is only 2. We're taking 16 extra still images plus 5 minutes of video, okay? Quite a lot of exposure. So let's come over now to the amount. 200 milligray distributed skin exposure, equivalent to 1,600 cigarettes smoked, quite a lot, 6,400 kilometers, or 70 years of natural background. Basically, it's an entire lifetime of natural background just for that one procedure. And some people will have, more than one of these procedures done in their lives, right? Okay, that's the highest level stuff, right? You don't see anything really higher than the angiography with a lot of fluoro on here. Now you come down to, just to give you some other reference, dental, right? Dental radiation, dental x-ray machines are still x-ray machines. They're so much more limited in what they can do that those dental assistants don't have to go through training like we do because their machines are different. They still produce x-rays, but they're so much more controlled. They don't get to make changes. They're very much the protocols are very much tighter, so they can't change things. Okay. Anyways, the point is, the dental X-ray still gives you X-ray exposure in the amount of about 12 milligray. 4 dental bite wings is like a part of an exam. It's not a whole dental exam, but it's kind of on average, an average idea. 12 milligray, so quite a bit more than the chest, right? One important thing to keep in mind is that the chest is very large and the mouth is very small, okay? So that those dental x-rays, the exposure is being confined to a very small area, and we said earlier that the amount of area that you x-ray matters, right? 1 milligray to the chest would be more effective than 1 milligray to a tiny part of the mouth, okay? This is 12 milligray to a tiny part of the mouth, but you still get the idea. It's a small area, even though it's a lot of, seems like a lot, it's a small area. 4 dental bite wings, 12 milligray, 100 cigarettes smoked. Still though, 4 years of natural background, right? So again, this should be, I think the natural background amount is pretty useful to see because it really shows you that it's adding on to your total lifetime accumulated exposure.
Like the L-spine. Like the L-spine.
Yeah, it's a lot, right? Yeah. So okay, let's keep going. A couple quick notes on that table that we just looked at. The 2-view chest study. We'll circle back to this. The 2-view chest study delivers about 4 to 5 times the exposure of a single chest X-ray. Why would doing only one more chest X-ray give the patient about 4 to 5 times the exposure as just the single X-ray? It says it on here, but you take a guess? Think about your settings that you make when you go from the AP, the front view chest X-ray, to the lateral chest X-ray. What do you change?
You get closer?
You don't get closer.
The amount of space you gotta go through.
Yeah, the body gets thicker. I don't. Maybe they were trying to say something like that. But the body gets thicker, right? So what do you have to change to account for that thicker body?
KVP and
Exposure, right? Your settings, your technical settings, right? KVP, MAS, you change those. By the way, on here, there's a couple bullet points right about that level for KVP and MAS, what those things mean. They're settings that we make on our machines that adjust how much radiation and how energetic that radiation is, right? All right, these are the adjustments to our X-ray beam. Yeah, because we have to deliver more exposure on the lateral, the side view, because we're thicker this way than we are this way, right? The exposure is going to be higher, 4 to 5 times higher for the 2-view chest rather than the single view of the chest.
The lumbar spine on the lateral.
Hmm?
The lumbar spine on the lateral.
Mhm.
It's a lot harder to get that exposed. I shot one and
Right.
it came out so dark. I'm like, oh my gosh.
Right.
Like just as much as Matt came in and the doctor came on do it this way. He even shot it and it looked like, oh, at least I see the 5 right there.
Was the patient very large?
Yeah, it's pretty big. Like
Sometimes it's hard when they're very
5'15", 5'10", you know.
Yeah, okay, well, that's not huge
The
though.
lumbar came out good,
Yeah.
but the lateral, I noticed that one was like, what?
Yeah, so that extra thickness really does have an effect, and you have to adjust your X-ray beam to account for that extra thickness. Okay, let me move on. Let's talk about this next table. This next table that we're going to look at here, 43-2, is gonadal dose to patients by exam. What are the gonads and why do we care about them? So let's start. What are the gonads?
Testes,
Testes in males and
ovaries.
ovaries in females. Good. They're the part of the organism that can create the reproductive cells, right? Testes and ovaries. Okay, so that's what they are. Why do we care about exposure to the gonads?
Birth defects and
Yeah, what makes the gonads at risk for radiation exposure?
they're the most sensitive.
They're more sensitive, right? Because those tissues are, to use the technical terms, less differentiated and highly mitotic, right? Those cells divide frequently, and they are not specialized cells yet, okay? That makes them more radiosensitive. Recall the whole talk we had about the scientists Bergoni and Trabando and Ansel and Weidenberger, right? We talked about those two groups of scientists at two different times in the early 1900s, and they said those things, right? Highly mitotic, cells that divide frequently are sensitive, and cells that are immature young cells are also highly sensitive, okay? So the gonads are important because we use those cells to make new people, right? And if those cells get damaged, the new people we make can get damaged too. Those are genetic mutations, right? That's what we worry about. Okay, so let's take a look. A skull X-ray gives roughly 0 milligray, so 0 exposure to the male and the female. Why do you think a skull X-ray gives roughly 0 exposure to the gonads? They're just far away, right? Good, good, good. We're confining our radiation field to the skull. Gonads are way down there, so roughly 0. Plus we do things like shield, right? Okay. Cervical spine, which is your neck, same thing. Shoulder, same sort of thing. Come down to chest, though. Chest tube view says 0 for the male, and then 0.01 milligray, so very small amount, but still something, 0.01 milligray for the female, okay? Why does the female get anything and the male get nothing? Is there a difference between the location for male and female gonads? They're inside the body, right? They're internal in females, where the gonads are external in males. That makes a difference. Okay, the difference in placement for the gonads, male to female, makes a difference. So then you come down to, ignore the upper GI one, but come down to the barium enema. Okay, barium enema series, 1.75 milligray for males, but 9.03 milligray for females. Okay. Think about what the barium enema is. If you don't know what it is, which presumably some don't, it's a X-ray procedure in which we take a liquid, basically a metal dissolved in water, barium, okay, and we plug it into the rectum, and we fill their entire large intestine with this liquid, okay? And we take X-rays of it, and it shows up bright white, makes their intestines show up bright white on the X-ray, and so we can see problems with the intestines, okay? It's a high-level exposure. It gives a lot more radiation to the female than the male because of where the gonads are in the female versus the male. They're internal in the female, so very close to where the primary X-ray beam is going to be. The X-ray beam going through, the abdomen area, the lower abdomen, abdominal pelvic region is where the gonads are in the female. Basically, you're exposing her to the direct X-ray beam. The gonads, her gonads to the direct X-ray beam, where the male's gonads are not in the direct path of the X-ray beam. They're getting scattered radiation and things like that. so lower exposure. But then look at the pelvis. Okay, pelvis and hip, down towards the bottom. So fourth and third from the bottom, pelvis and hip. See how it flips? Males get more than females for those exposures. Why? For the exact same reason. It's location, right? The male's testes are external, where the female's ovaries are internal and protected by the skin, the muscle, all of that on the abdomen, where the males don't have that, right? There's nothing really protecting the male's testes. So the pelvis and hip exposures give more exposure to the male's gonads than they do to the females. We have to consider those things when we take all of these, perform all of these studies. It's not just males get more than females for all exams, and it's not just females get more than males. It's dependent on the exam. One will get more than the other. Okay. Everyone feeling okay with this information so far? So we've taken a look at patient exposure levels. So now what we're going to do for the next few slides is, what can we do to lower patient exposure levels? Okay. So the next thing I'd like to do, if you have this already, just don't grab one, but go ahead and snag one of these. This is the technique chart that the school uses for our x-ray machine. So let me briefly, as this is going around, describe what this is. So in every x-ray room, right, we need to take x-rays of the body, and we don't just have to guess how much radiation we're using for every x-ray procedure. We are given a piece of paper, usually put on our wall, that tells us what settings to make on our equipment for the exams that we're doing, okay? This thing is called the technique chart. The settings that we make are called our radiographic technique. So radiographic technique is not some special technical thing you're doing. It's just referring to the settings that you make on your equipment. Those settings on the equipment that you make are derived from a technique chart, and this is a technique chart. So you'll notice it lists, the left. So you notice the left column, it's split into columns, so you read it like columns. You notice the left column shows you all the body parts. One column over from that shows you the projection. AP means a front view, lateral means a side view. And then there's a bunch of specialty names like oblique and Towns and Water and Caldwell. Don't worry too much about that. But what I want you to pay attention to is, actually, you know what? Let me hop out of this real quick, because I can actually bring this up on the screen here.